We are here to celebrate the publication of Dr. Jim DeMain's first book, Facing Death, which is a very personal and heartfelt account of all that he's learned from patients facing their final moments and the families of patients. I'm just so excited to introduce you and get going. I just want to quickly say, Dr. Jim DeMain brings his knowledge from a nearly 40-year career in medicine to the lessons in this book. And in addition to being a pulmonary and critical care specialist, Dr. DeMain was also co-chair of the ethics committee for group health in Seattle, which is now Kaiser Permanente group in Seattle. So that's a pretty well nationally known and enormous healthcare group. Dr. DeMain began the stories that resolved into this book through his End of Life blog, which still exists, and it's endoflifeblog.com. You guys can go there. He began it in 2009 after having heard so many stories of patients and their families facing the end of life. And that has kind of all coalesced into this volume. We are so grateful to have Jim's wisdom here, and I encourage you all to type any questions you may have into the chat feature at the bottom. You can just kind of go to the bottom of your screen, hit chat there, and type in some questions. Jim will probably be answering them just through his remarks, but I will try to get to some after about 20-25 minutes when we'll do a little Q&A. So thanks for all coming, and Jim, take it away.
Thanks very much, Claudia, and thank you all for coming. I really have so many people to thank for having this project come to fruition. Claudia is a wonderful editor as well as a wonderful writer. She kind of held my hand and helped me glue the stories together and make it more cohesive than it would have been otherwise, for sure. I want to thank, of course, Brick and Mortar Bookstore for sponsoring this. And I'd really like to break at this point, but I can't do it, is to ask you all why you are here and what you're interested in the whole issue around death. It's something in the past that we didn't talk about much. And it's something that we can't practice. We only die once, hopefully. So, and it's something we didn't talk about. It's kind of a strange thing in our society that we haven't done it, because it's a universal thing that it's going to happen to us all. But we go about our day-to-day lives pretty much in denial. I would make rounds in the intensive care unit during my career, and I would very often find somebody struggling with end-of-life management issues. And it usually in the intensive care unit would be somebody is very, very ill. They are on a ventilator with life support, and they may not be doing well, or may have been going on for a month or 6 weeks and weren't making progress. And we were struggling with, well, what would this patient tell us if they could? And so often people had not had the conversation. So that's one thing I emphasize over and over in my book is please have that conversation with your loved ones about what your wishes are. Because toward the end of our lives, in the last couple of weeks of our lives, we really aren't going to be able to participate in that conversation. I was talking at the dinner table with a lady one night. She was 92 years old, and this subject came up, and I asked her, well, have you had discussion with your family or filled out any forms? And she said, no, I will when the time comes. So it's something that we tend to delay and tend to deny. So as these stories came up, I decided that I wanted to do more educating of individuals. And at Group Health, we developed a course called Your Life, Your Choices. And in the community throughout the past 10, 11 years at least, we've been going to clinics and inviting everybody over age 65 to come in and have that discussion. Lasts about an hour and a half. We give them the forms. We kind of handhold a lot and have a lot of questions. This is not a one-time process you go through having the conversation. It is something that even if you've filled out your advance directives, and by the way, only about a third of us have filled out advance directives. In fact, when I went to the law school with actually Greg's wife's a law professor there, I was talking to the class about end-of-life issues and asked how many of them had any advance directives of their own. And of course, these young people had no advance directives, even though they were arguing the case about whether a young woman should have filled out advance directives. So all of us tend to put this off. So what I'd like to do is maybe read a little bit from the book. It was supposed to come out yesterday, but as you know, the debates took precedent last night. I hope you enjoy this discussion more than I did with the debates. It was a sight to behold for sure. The session, the chapter in the book that I'm going to read to you is about palliative care. I'm sure most of you know what palliative care is, but it's a relatively new specialty. It doesn't focus on one organ or one disease. The intent is to look at the patient holistically and try to help relieve their suffering. Palliation really kind of means relief of suffering. It can be pain, it can be shortness of breath, it can be all kinds of issues. And looking at the big picture, they will often come in when somebody's having difficulty, even with hospice, they'll consult, but commonly with non-hospice patients where it's very complex, multiple specialists are involved, and it's kind of the picture of the whole patient is being lost. So this is a little section called aggressive palliative care. In the days before hospice, pain management was episodic at best. It's hard to believe that I was never taught about pain in medical school. Well, that's not entirely true. We were told to make sure patients didn't get hooked on narcotics. Nurses were drilled similarly. We learned about disease and disease processes, but not much about the full scope of a patient's life in any holistic sense. Richard was initially referred to me because of masses in his lungs. Being a pulmonary specialist, I would sometimes see primary lung cancer, but also lung cancer that had spread from elsewhere. During the evaluation, it became clear that the primary site of his cancer was in the left kidney. A silent cancer had spread its tentacles before symptoms ever developed. Now Richard had multiple metastatic tumor growths also on his scalp that were excruciatingly painful. Narcotics were necessary. The scalp lesions began to ooze blood and enlarge. Radiation and chemotherapy were ineffective. I began to receive calls about Richard's narcotic use from the hospice nurse. He was asking for increasing doses of both long-acting and short-acting opiates. The nurses were becoming concerned, so we met and discussed the goal in this case, pain relief. Often large initial doses of narcotics are used for pain control, leveling off with consistent lower doses to avoid peaks and valleys. The dose we agreed on was enough to effectively control his pain. But Richard was now in constant agony and pleading for relief, so his nurses carefully escalated the morphine dosage. That was successful in controlling his pain, and Richard died in 3 days, much more comfortable, but sedated to the point of unconsciousness. As mentioned above, nowadays, a palliative care specialist would consult with hospice on such a case. With multiple specialists involved, the palliative care specialist would help to direct an overall care plan, coordinating treatment and symptom control, while ensuring that the focus remains where it should be, on the patient's needs, whether that means pain management, nausea control, or treatment for depression. Unfortunately, though palliative care centers have been established across the United States, there are simply not enough palliative care specialists to meet the needs of all patients. Some intensive care specialists also specialize in palliative care medicine. Very unusual combination, but there are a few that take their boards in critical care medicine and then see a different need for palliative care at the end of life, and they really bridge both worlds. But until we can ramp up the numbers within the growing specialty, palliative care skills should be taught to all medical specialists, especially those in primary care, and those, I might say, that are hospitalists caring for patients in the hospital. So that's the field of palliative care. We're fortunate in Seattle to have a wonderful Cambia Center for Palliative Care Excellence based at Harborview and University of Washington. And my friend Randy Curtis runs that program. They're training multiple specialists and have wonderful conferences in the area. And being still an advocate for friends and relatives and others, I've referred more than one patient to that service to try to sort things out when things are really difficult. You might question the ethics around the case that I just presented, but it's kind of an interesting concept. It's called the dual effect. It depends on your intent. The intent of the nurses that were administering the morphine to my patient was to relieve his pain. Their intent was not to basically kill him, to put him out of his misery with that intention. And this is actually acceptable to all medical societies. It's been tested in court. And it's something that I think in the past we were reluctant with pain medications because we might be criticized. There's another story in the book where I relate back in 1938 in Madison, Wisconsin. My father was an intern, and they had a patient with multiple myeloma with multiple fractures of the bone. And in that era, there was a reluctance to use morphine, and there was a fear that they would be charged with causing a death. So the interns made a pact among themselves that every hour, one of them would go in and give a dose of morphine to the patient, and they would rotate this to the point that nobody really knew who gave the fatal dose. But hopefully we're much better than that now. We can be upfront with what we're doing and how we're doing it. And this is a lead to discussion with Death with Dignity that I go on and have a few chapters in the book about, but won't discuss that further here. The subject of ethics comes up in a book really quite frequently. And when we're dealing with end of life, we're really looking at respecting an individual's autonomy. That's very, very important in American view of ethics. We should have our wishes known, we should have them followed. And that throws responsibility back on us, of course, to make those known. And then there is the age-old ethic of do no harm, first do no harm. And I think all of us physicians certainly have that at heart. Another one is beneficence, which means literally doing good or trying to do the right thing. The question is who decides what the right thing is? And beneficence was pretty prevalent when I was in medical school. Doctors know best. We knew better than the patient, and we would try to do the right thing. But that has flipped now, and autonomy is certainly much more important. But sometimes the ethics aren't clear, and I want to read another short passage here. And I titled this one called Ethics on Thin Ice. Doctors sometimes walk a delicate line in honoring our vow to do no harm when operating in a manner that is medically sound. Consider the case of Shirley. Every 2 weeks, she was taken by ambulance from her nursing home to our ER for blood transfusions. These transfusions were keeping her alive. The problem was that every time Shirley was moved, she decompensated. Her Alzheimer's was very severe. She no longer recognized her family. At 83, she was slowly dying. Shirley had aplastic anemia. Her bone marrow could no longer make enough red blood cells to keep her alive. Medications to stimulate red cell production were no longer working, and by medical protocol, Shirley's transfusions could not be given in a nursing home, so she arrived every 2 weeks to get 2 units of packed cells in our emergency area. Poor Shirley often screamed when stuck with needles. She'd then require sedative medications and wind up getting admitted. It was kind of a medical merry-go-round, though not so merry. This time, I was on call. Shirley had perhaps 10 admissions already. I didn't feel the transfusions were extending her life in any beneficial way. They appeared to be making her miserable and prolonging her death. So I gathered her husband and children for a discussion about end-of-life plans. We set aside an hour late one afternoon. The social worker who had been working with Shirley's family joined us, as did her primary nurse. We reviewed Shirley's medical history and asked the family to fill in missing details, encouraging their participation. There were many moments of sadness and some expressions of if only, but in general, the family seemed to have a realistic understanding of Shirley's poor outlook and even worse quality of life. Then we discussed various scenarios around the issue of more blood transfusions. When I brought up the option of hospice and no further transfusions, Shirley's husband, Maury, jumped out of his chair, very agitated. "This is like Dachau," he shouted. The room was silent as he stomped out. The others kept talking. They noted that Maury had early Alzheimer's himself and required ever-increasing supervision, yet they wanted to honor his feelings. Shirley had never completed an advance directive, but her family felt certain that she wouldn't have wanted to continue living in her current state. Given this impasse, I suggested a one-on-one meeting between Maury and myself. The next day, we sat down to talk. Maury was no longer upset. In fact, he seemed eager to discuss Shirley's care. In broaching the ethics of the situation, I explained that Shirley's blood transfusions might actually be harming her. "You know, I agree with you," he said, to my great surprise. "Why is that?" I asked. "She might get AIDS." With Maury fixated on his fear of AIDS, the family determined that there would be no further transfusions, even though AIDS-contaminated blood was not the issue. Hospice was begun and provided wonderful support to Maury and the family as Shirley went downhill and died peacefully in her nursing home several weeks later. Perhaps it seems cavalier, ethically speaking, to have stumbled upon this way of getting Maury to agree with me and the rest of the family, but his decision-making was impaired, and the do no harm principle was my primary guide. Still, this case is anything but textbook. As I said, medicine is an art as well as a science, and very often a delicate balancing act between the two. So that's all the reading I plan to do from the book. I would like to show you a few slides, and I'm going to try to screen share here, and we'll see how that goes. So this is the book, and it's kind of odd to see my name on something like this, to live 81 years without producing something like this. I feel it's kind of a late conceived child of some kind, but it's a brand new experience for me. William Saroyan said, "Everybody's got to die, but I've always believed an exception would be in my case." And I think that's the way we all feel in a way. I think denial is actually okay. We go about our daily lives. I do have a section on COVID-19 in the book. It doesn't dominate the book in any way, but I think the current pandemic has brought this subject to fore. I mean, we're reading about deaths in the paper every day. We're reading about isolation and depression surrounding this, and the minorities who are involved. So I do touch on that a bit. And I also like to remind people who are in denial that world mortality rate continues at 100%. This is from the humor magazine, The Onion, and it usually gets a laugh. In fact, somebody asked me why I haven't updated this slide, but I don't think it would change much. So several years ago, I was interviewed on KUOW by Katie Sewell. And in fact, Katie is going to be interviewing me for a town hall presentation on November 16th, if anybody is interested in listening to more about this. But her first question to me was, Jim, what's a good death? And I stammered and stumbled a little bit. And I said, well, it's actually, I think, when somebody's wishes are adhered to, whatever they are. We all have a different feeling about death. We'll probably all die in different ways. Again, it's something we can't practice. So as I thought about this, I've written more about it in the book. And part of it is preparation. Are we really ready on a spiritual plane, an emotional plane? Have we had our physical complaints well attended to? Are we getting good medical care? Our wishes have to be known and honored. This gets into the whole field of finding an advocate, somebody that can really speak for you. And I tell people, if you have only one thing to do, find that advocate, have a conversation. Because when I would be at the bedside in the intensive care unit, I would turn to the advocate and we would have deep conversations, even if you have advanced directives filled out, because the whatever your wishes are can't be completely spelled out, because there's always nuances that come up. We need good pain and symptom control. We need hospice and palliative care. And I think that's so important, because in prior days, people would feel abandoned. We need a sense of completion of goals. We have different goals. There's a interesting article that's going to be coming out, I think, in the New York Times, on people trying to stay alive in order to vote. They are on their last legs, but by golly, they are going to stay alive because they want to vote. And that's either way. We want to be able to contribute to others and have a legacy. I think that's important to all of us. And be at peace and surrounded by loved ones. So I think at this point, I'm going to stop the share. And it looks like, Claudia, you may have picked up a number of questions or comments in the chat room.
Jim, I'm sure that as people are getting toward the end, they are in whatever way, patients and their families are in whatever way, maybe it's at the last minute, but kind of trying to grapple with the various issues at whatever level. What do you think is most often overlooked? What do you think people don't prepare for, don't think about as they are grappling with the end?
Well, one of the hardest thing is a complete mind shift from what I call the curative mode to the just supportive or comfort mode of care. We really kind of have three choices toward the end of our lives, or at any time. One is do everything, go all out. We're all signed up for CPR. Society says it's worth saving a life. So, if we fall down in the mall, a stranger can come and bare our chest and begin CPR. That is kind of the standard now in our society. Then some will choose various care. They say, I'm willing to have a hip done, but please never put me on life support. But when somebody's on life support, it's very difficult, because then the family, we always want to keep our loved ones alive, and we always want to keep an optimistic mode that they'll make it through. That isn't always the case. And it's so, how do we learn to let go? How do we shift gears? Atul Gawande's book is really a groundbreaking book in helping us to talk about death. And he has a chapter in that called Letting Go. And it's an extremely hard thing to do with a loved one. And sometimes it takes time. But sometimes if you've made plans and you've really told your loved ones what you want, then they basically then have permission to let you go at the end. But it's that existential switch from do everything to comfort that is so difficult for families.
So it sounds like it sounds like you're speaking primarily about families and survivors. What do you think most frightens an individual facing death?
Well, a lot of that's going to depend on their background. If they have strong faith, if they, it probably fits into the personality type. I've had some non-believers say, hey, I'm ready to go. That's that. I've lived a good life. And I think they've had a sense of completion and a sense that they've done everything they can. They've said their goodbyes. I think people sometimes are afraid of things undone or promises not kept, apologies not made. So I think it's just quite different for each individual. I had one lady that I wanted to send for a lung transplant, and she probably was a good candidate, but she said, no, that's just too invasive. I'm in the Lord's hands, and whatever happens will happen. And she died very, very peacefully with hospice.
So as an ethicist, how do you handle cases where a family or an individual continues to want more and more treatment, more and more costly treatment, when you know that the individual will perhaps never regain consciousness, and yet a family is continuing to insist on care, expensive care, and resources expended on a person who is, for all intents and purposes, in terms of consciousness, gone? What do you do in such a situation?
Well, fortunately, that doesn't come up too often, but it's never easy. The process that we use in the intensive care unit is called shared decision making. And we got training in ethics from a wonderful Jesuit priest named John Galinsky, and he came up and kind of walked us through kind of a situation where you really try to gain trust. You try to form what he called a moral community, where everybody had a say in a family conference. Everybody was listened to. You delve very deeply into what the life of that person was. And I use storytelling. I would say, we had somebody just like your mom here last week, and then they would divert their attention. And then sometimes they would find, well, it's okay to let go. Sometimes, though, they would fight on, and then we would run into what in medicine we call futility, where the family simply was not willing. And these can become legal cases where you have to look to get a guardian if somebody is really in an abusive situation. And sometimes the hospital ethics committee can review a case like this and make a recommendation. Although they don't make a final judgment, they can make a recommendation. And occasionally a hospital will say, we've done everything we can with the care we're providing is not beneficial, and give the family time to look for another institution. But that doesn't really solve anything. That rarely came up. We did have one at Group Health in the early days where the patient was kept alive more than a year on a ventilator, and they were calling the Seattle Times regularly. So I think people are worried about adverse publicity and lawsuits. Although honestly, there aren't that many lawsuits about end-of-life care if you've had good communication.
This is a question from a listener and a viewer. Are doctors better than the average person in terms of their own preparation and in filling out advance directives for end of life?
Well, somebody wrote an article about how much intervention doctors would want to have toward the end of their life, like CPR and ventilators. And they were much more willing to say, I don't want any of that stuff than the average person, because we know the downside of those kind of interventions. A lot of it depends on the baseline that you start from. If you're frail and elderly and have significant underlying disease, the survival of the heroic intervention is not good at all. It's probably less than 5%. But there are some people, even in their 60s, that say, when I go, just don't do anything like that. And then there's the Dr. Ezekiel Emanuel. I have a chapter about him in the book. He wrote an article in the Atlantic, Why I Hope to Die at 75. And he felt your life was complete at that time. And he didn't want, he said he wouldn't even accept an antibiotic. I think he did that a little bit tongue in cheek, but I wrote kind of a scathing criticism of that because I thought it had a touch of ageism and kind of unrealistic concept of how much people over the age of 75 can still find a lot of enjoyment in life.
As you are a great example of yourself in doing this book. One of the listeners here asks, what questions do patients ask you when they know that death is approaching?
That's a good question. I can't think of anything specific, but sometimes they'll ask me if they're doing the right thing, have I made the right choice. I always encourage them to talk to their loved ones, to whoever their spiritual guide is. But yeah, sometimes, they'll say things I know that really aren't their wish. Like I had one fellow with bad emphysema in my office, and he said, "Hey doc, listen, no tubes. I don't want any tubes." And I said, "Well, you're still functional. You're still going about your daily life. If you got a pneumonia and we're not breathing well, I might have to put a tube down your throat and put you on a breathing machine for a week or two, but you have a good chance of getting back to the way you are now." And he said, "Well, of course I'd want something like that." So sometimes you have to be careful what you wish for.
And what about mistrust of hospitals and medical institutions? I am hearing that with COVID, that patients or their families may feel reluctant to tell a physician everything that the patient wanted because of a fear that they would get subpar care or that they might not be put on a ventilator as long. Do you have a sense about how COVID may be affecting patients and their families in terms of their candor with their own doctors in terms of what they want?
Yeah, there's a lot of trust issues, particularly in the minority communities, African Americans particularly, that have such a poor record of the kind of care they've gotten in segregated wards in the Tuskegee syphilis experiment. And I do have a section in the book that talks about their mistrust, even in hospice. So it kind of depends on the baseline you're coming from. The COVID epidemic has thrown all of us in a loop, and articles are coming out left and right, kind of redefining things. But the problem of going into the hospital is the isolation, complete isolation that people have that have COVID infection, and they cannot have their loved ones with them. There are some exceptions now. Toward the end, they are allowing loved ones to at least come into the room. But I think the COVID epidemic has isolated a lot of people. I think seniors particularly are more isolated, and I think there's depression. This thing is going to be with us for quite a while still, and the medical system has ramped up pretty well. In most areas, the hospitals aren't overrun. They're screening people. I go see the doctor a fair amount, and I get screened, and I figure with the mask and social distancing in the waiting rooms, and everybody's masked and careful and hand washing, that they've done pretty well, actually.
A watcher asks, says that they would like to write down what quality of life is important to them. What kind of information would be helpful or important for a doctor to have when interpreting a patient's wishes? I mean, as you say, you can't devise you can't write every scenario.
Right.
And this question brings to mind a really poignant story in your book where there is a wife and her husband is dying. He has Alzheimer's, I believe, Alzheimer's or dementia, and she, she's essentially his agent, but he can't say what he wants, and it's kind of all on her to figure it out. I think that's what this question is getting at. What's important for a doctor to understand about a person in order to make their best attempt?
Yeah, of course, the individual hopefully will have had a conversation with their advocate, because we really need the advocate to be there when the individual can't be expressing for themselves. There are a number of things on the internet, value statements, wish lists, that kind of thing. I think it's very valuable to write out an essay about your core values and what's really, really important to you. Those things, in fact, I have one in a book that a patient handed me and said, please attach this to my advanced directives because I want people to really know me. In intensive care, with a chronic patient, they bring in pictures, wedding pictures, family pictures, trying to humanize the person so we really get to know them as an individual. And unfortunately, in modern hospitals, that's really hard to do because your primary care physician no longer comes in to visit you. Well, it may be socially, but not care for you. So we have hospitalists and specialists. So it can feel like nobody really knows us. So I think advocacy is critical, and having somebody that really knows your heart and that you've had that deep conversation. And these conversations aren't a one-time affair, because your wishes will change over time depending on your age, your health status, and that kind of thing.
If it's not too intrusive, and since you did write a book about this, I'm going to ask you, what's your own idea personally of an ideal death or a good death for yourself?
Well, it's kind of the points that I mentioned. I think my wife and I talk about certainly not wanting to be alone, wanting to have loved ones there. It will be a new adventure. We both have a belief that in a life to come. There's naturally some fear of suffering, but yet I think I have trust in the hospice system and in the care system that we have now. Personally, I doubt if I'd want to ever use death with dignity, but I'm glad that law is on the books. And who knows? We won't know until that time what we will really, really want. But I think those kind of things are important to me, and death will be a new experience for me. I've been around it a lot, but it's something that is hard to imagine, even though I think about it.
So clearly, families are a huge part of this equation in kind of navigating the end. Do you have advice for people listening about family members who might shut down that conversation and say it's too hard, or it's too frightening, or it's too depressing? The patient may be really wanting to have this conversation, but the family may be so frightened that they don't want to. Do you have advice on how to get around that?
There's a really good website called the Conversation Project, and you can just Google the Conversation Project. It's by Ellen Goodman, who's a Pulitzer Prize-winning author, and her mother had what she would call not a good death. And she has regrets for maybe not communicating, planning around that. So the Conversation Project not only has all the forms you need to fill out and that kind of thing, but they have starter kits as to how to do exactly what you're talking about, how to approach your family. They have videos. other helpful hints. There's even card games and other things like that that are conversation breakers. There's some other attempts to get people to talk about death. There's a website, Michael Hebert at the University of Washington started this movement called Let's Have Dinner and Talk About Death. Conversations traditionally occurred around the dining room table in America. That doesn't happen much anymore. So they have these kind of structured dinners where you can go and with some of them are strangers and you talk about death and dying in an open fashion. And of course, there are meetup groups called death cafes. But one woman I had, she filled out all her directives completely. She Xeroxed copies. She mailed a copy to all of her kids and then called a family meeting and basically went around the room saying, do you agree? Do you agree? Do you agree? She didn't want dissension in the family. And one thing I might mention under Washington state law, if you don't have directives and let's say you don't have a spouse, all of your adult children have to agree on a plan. So if you have 5 kids and one of them disagrees, then you're in limbo in terms of making medical decisions for somebody.
So what happens?
What happens, you go back, you try to do shared decision making and you take time working through this problem. But that's why it's so important. Automatically in Washington state law, it would go to your spouse if you have one. But if you have adult children, they all need to agree on the medical plan. So that's been a real problem from time to time.
What do you see looking forward in the medical field, if anything, on training physicians to deal with this issue? Maybe, you know, it sounds to me from looking at, from editing your book that there is kind of a nascent effort to bring some of that training into medical schools.
Yeah, I think that young doctors and medical students are way ahead of the game from where I was. When I was in medical school, we wouldn't even tell a patient they had cancer. We'd whisper it to a family member, and we certainly didn't talk about death. And so we saw a lot of kind of unrealistic hand-holding that went on with dying people where they were kept in the dark. So yeah, it's happening. I really wish that more medical students had liberal arts education before they went to medical school, because although medicine's a science, there are so many other things that are on the human scale that they need to be comfortable with and deal with. And some of my colleagues were great at that and some weren't. Don't be afraid to find a doctor that you can really talk to, I guess, for your primary care particularly.
Are you seeing, it sounds like you're saying you're seeing a bit of a generational difference in physicians in terms of older and younger doctors who are more or less willing to talk about this?
I think it's getting better. Certainly with the younger physicians, the hospitalists are all trained in that. Then you have other people that like social workers that are quite good about bringing up the subject. But and especially like oncology, which dealing with cancer patients, sometimes they're still not willing to give up. You know, there's always one more drug, there's always one more treatment. There's this experimental thing that we can try here or there. It might give you 2 months more of life. And a lot of it then is going to be variation, finding the kind of person that is going to match with you. So I would encourage people, if they have a serious illness and they feel they really aren't being listened to or understood, is to talk around and maybe find a second opinion.
How good are doctors at respecting advance directives, especially in cases where perhaps the patient has laid out very clearly what they want or they want to go, and the physician, as you talk about so often, so eloquently in the book, about this mind shift from curative to palliative, the physician often is, in your experience, so oriented toward curing, where the patient and family may be ready to go. So this listener's question is how sensitive, how good are doctors at respecting a patient's advance directives, even if it goes against the physician's instinct?
There's probably more variation than I know. Sometimes the advance directive gets lost in the shuffle. For example, and I write about this in the book, my sister Julie was admitted with a stroke, and even though she had a wish in her advance directive not to have tube feeding, they did insert a feeding tube through her abdominal wall into the stomach before the family produced the advance directive. So sometimes the advance directive isn't immediately available, and sometimes it isn't asked for or looked at in the rush of providing care. So and sometimes the medics on the scene have to use some judgment. You know, even when they arrive with a 911 call, it may not be totally clear whether that patient wanted to be resuscitated or not. So it isn't locked into stone that it's always going to be followed. Most of the time it is. I mean, we would talk to the patient, you know, what would they want? In the early days of the AIDS epidemic, it was so sad to me to go into a young man's room and kind of tell them that to move them to the intensive care unit just wouldn't be beneficial. And that's now called informed assent, where we're not throwing the burden on the patient saying, don't do this, or the family, but we're kind of being a little bit directive. It's called informed assent rather than informed consent. And so that situation was very, very sad with those patients. And certainly in senior care centers, the advance directive is universally used. And there's this form that people might be familiar with. It's called the POST form. It stands, it's different color in each state and a little different form. And all states are developing one if they don't have one already. It's called the MOLST form in some states. It's medical orders or physician orders for life-sustaining treatment. It's kind of a unique form because it's signed by the patient and the doctor. So it's actually real legal standing medical orders. And so Medic One, if they arrived and they found one of these completed and it says do not resuscitate, they're very relieved not to have to do CPR and that kind of thing.
And so then should people have them sort of very visible in their homes? I mean, when a medic comes, they're not going to go like looking through your papers, are they?
No, they don't have time. They're going to be standing over you. We actually, in the place where I live, when I was chair of the healthcare committee, we standardized it for the building. Everybody that has a POST form will put it in a hanging plastic folder on the inside of their kitchen sink, so that everybody in the building knows where to find the form. Some states allow or promote having a wrist or medallion that says do not resuscitate. And Washington State does not have a law that addresses that, although I think they should have validated medallions or bracelets that say do not resuscitate. Because otherwise we're all signed up for CPR, even if we're 100 years old and we're shopping down at Nordstrom. If we go down, somebody's going to do CPR unless they know otherwise. So some people will carry it in their purse, or they'll always be with somebody that has a form with them. And the medics will pay attention to your spouse if you happen to be there. I mean, they don't want to break a lot of ribs like they do in older people doing CPR. But none of these forms are foolproof. The most foolproof thing is to have your advocate with you at the time those decisions are made. And my friends at Washington State Healthcare Advocacy Association are very familiar in promoting that and that kind of care, particularly in the hospital where you need somebody that can advocate for you.
So if, for instance, you don't have a spouse or a child who's nearby, or your spouse or child doesn't want that responsibility, there are places where a patient could get somebody to be their advocate, their agent for them.
Right. Yeah. I have, after I've given a class, every once in a while somebody will come up to me and said, I just don't have anybody to be an advocate for me. And WASHA, the Washington State Healthcare Advocacy Association, will help people find advocates. It's basically, it's not a free service, but it's not terribly expensive. And they will help you to find an advocate. And that's extremely important, particularly as we get near the end of our lives and don't have anybody else around.
I just want to let our listeners know we're just a couple of minutes away from wrapping this up. So if anybody has been shy about questions, now is the time to start typing. And I want to say also before we go that anybody who wants a signed copy of Jim's book, they will be available at Bricks and Mortar, which is in Redmond, Washington. And that's starting next week. There'll be signed copies there. Of course, you can always go to ClydeHillPublishing.com website and every other bookstore website, of course, Amazon, but go to Bricks and Mortar, go to your local independent. And let's see, any other questions here? Jim, have we missed anything that you wanted to get to?
No, at this point, I would say just go read the book if you want to know more. No, that's I really admire people sitting through a session like this because we tend to put this off. We tend not to address it. And I think it is important. And my wife and I even put off discussing this, but every once in a while it'll come up and say, you know, did we do this or shouldn't we talk about this again? You know, particularly as we now say, well, you know, if our heart stopped, would we really want to have it restarted? So these are tough questions, and our feelings may vary certainly over time.
What I would like listeners to know that one of the things that's most interesting to me and unusual, I think, about Jim's book is that he strives to, Jim, you've strived to make it broad enough to encompass different traditions, both religious and cultural, different ways of approaching death, different fears about death that, and different ways and fears of approaching death in different traditions. I love the story about the woman who went back to the Philippines when she knew she was dying to see her family. And if you could just maybe tell very quickly in our last 5 minutes here, because I think what she had was truly a good death. This woman that you visited at the end in her home. Can you talk about that?
Sure. She was a delightful woman of Asian descent who had a diagnosis called primary pulmonary hypertension. It's a mysterious illness. We don't know the cause, so they gave it the title primary. But she was just noticing shortness of breath and some swelling of her ankles. And was tried a few therapies, nothing seemed to be working, so she was referred to me. And with various tests like cardiac echo and cardiac catheterization, it was determined she had very high pressure in her pulmonary arteries. These are the arteries that go from the heart to the lung. Usually it's a low pressure system. And when it's a high pressure system, the fluid tends to back up and there's just not enough circulation going through the lungs. So she was getting more and more short of breath and got to the point where she needed oxygen. And there are a few medications available, one even an intravenous medication that we tried. We ruled out things like blood clots in her lungs and fen-phen, which can cause this condition. And so we got on this track of just following her along and it got to the point, though, that she was getting worse, but she told me she was going to take a trip to Guam. Actually, it was Guam, not the Philippines.
Oh, sorry.
And because family was there, and she and her husband went, and she sent me a postcard telling me she was doing okay. And we got oxygen for her in Guam. And then she got back to the States. She was really doing worse. So I had her husband come in, and I talked to them about having lung transplant, because this is really pretty good therapy, and the only life-saving therapy available is somebody like that. And she just said, no, I really don't want to go there. You know, I'm content with my lot, whatever it is in life. And she just had this nice smile on her face, and she looked over to her husband, and he smiled at her, and then we just kind of followed her along. She got worse slowly, and got entered into hospice. And I would get notes periodically, kind of electronic notes that came in from the hospice nurses, who had her on some low dose morphine to control her shortness of breath. And so I wasn't really seeing her regularly as a patient, but I got a call from the hospice nurses one day that wouldn't it be nice if I could go visit her, because she really wanted to see me. So it was a house located in Bellevue. And so I worked at the Eastside Group Health Hospital. So it was not a difficult place for me to get to, and nice neighborhood, and pulled up into the driveway and knocked at the door, and I could hear music and laughter coming from within the house. A little grandchild answered the door and called for his grandpa. And they came over and ushered me in, and there was her bed, a hospital bed, set in the middle of the living room. And typical Asian fashion, the dining room table was absolutely filled with food. The kids were running around playing. They had music on, and she was comfortable in bed, had a very sleepy smile on her face, said, Dr. Demain, you must be hungry. Why don't you get something to eat? So she was kind of actually looking after me. And I sat for a while and listened to her with my stethoscope, and just kind of absorbed the ambience and tremendous admiration that I had for her and her family, and this kind of wonderful legacy that she was leaving for her family about death and dying, and how it is a natural part of life.
Right.
And
They were sort of celebrating where she was with her, right? They were sort of.
she was right in the middle of it.
Yeah.
And they knew she was dying, and they were yet supportive. And I found it just culturally very, very interesting and wonderful.
And
Really,
the opposite of
Great
frightening,
time.
actually. The opposite of frightening, right?
The
The
opposite of
opposite of frightening, not at all frightening.
not frightening. No, not frightening at all.
Right.
Yeah.
It is 8:00, so thank you to Jim Demain, and thank you to all of our listeners and viewers, and the great, great questions. See some people applauding out there. And pick up Jim's book. It has so many stories in it. It is really many, many, many stories, and enormous amounts of wisdom. And I'm just so grateful to have had the chance to work on it with you.
Thank you, and thank you, everybody. I see everybody from my best man to one of my residents at Wisconsin, and people scattered around, friends from Connecticut. So yeah, thank you, everybody, for coming and listening. I really appreciate it.
Bye, all.
Bye, all.
Well, that was interesting.
Yep.